It's 10:33. I think we're going to start so that we stay on time and everyone can go to lunch. With that, we will start off. Dr. Holder? So one thing, just a quick review. Everyone has 5 minutes to give your talk. The slides will go blank at 5.5 minutes, and then we will have a discussion, okay?
Good morning, everybody. My name is Tara Holder. I'm an interventional cardiologist and vascular medicine specialist at Prisma Health. I'm a recent graduate of Vanderbilt University Medical Center, and I'm here to present a case of no fluoroscopy, no problem, a case of lower extremity edema in the data-free zone. I have no disclosures. Here we have a case of a 28-year-old gravid female. She's about 30 weeks pregnant at the time, who presented with worsening left lower extremity edema to an outside hospital. She had a history of DVT and was on prophylactic Lovenox throughout the pregnancy. During this index presentation, she got a new diagnosis of DVT, and her Lovenox was then increased to 80 milligrams twice daily. She was then seen in our clinic 2 weeks later. Her past medical history is notable for a DVT 2 years prior. She had a prothrombin gene mutation. She was a heterozygote. It's unclear the significance of this. Social history, she's a non-smoker. Surgical history, at the time of her prior DVT, she had left iliac vein stent placed. She has a family history of thrombophilia and medications. Previously stated she was on Lovenox twice daily and prenatal vitamins. So this is her initial venous duplex imaging. So on the right here, you have her grayscale image. You can see the stent. And then the second image, there's no pointer on this, but you can see that there's no color flow within the stent, and the Doppler, there's also no Doppler signal. So this stent is completely occluded on her initial venous duplex imaging. So the technical challenge here was how to treat this patient without fluoroscopy. She's at least 30 weeks pregnant at the time. You know, typically for these, you might want a prone popliteal vein approach. Not an option due to her gravid uterus. Also, even a frog-legged approach might be challenging because she has significant lower extremity edema. Whoops. All right. Let's go one more back. So here we actually went for a left mid femoral vein approach. Oh no. This isn't playing. Oh, there it is. So this is, after we got her venous access, we were able to go up with an 035 wire and then use an 035 IVUS. That pulsation there is the iliac artery, and just distal to that you see a stent with thrombus within. The thrombus actually extended throughout the stent into the left common femoral vein. So what we're seeing on this IVUS is that the prior placed stent actually missed the area of compression. So just a review here. So this image is showing, you know, our compressed IVC because of her gravid uterus. That red star that you see there was the right common iliac artery that was compressing the iliac vein, and there's no stent at the area of compression. And just distal to that, we are seeing a thrombosed iliac vein stent. So at this point, we decided to go with mechanical thrombectomy. We actually upsized our sheath, and we went with a 24 French flow treater device via the left femoral vein, and multiple aspiration passes were made. After each aspiration pass, we actually re-IVUSed to make sure that we were removing thrombus. Once we removed the thrombus, we then obtained right common femoral vein access. The reason for this was then to use our 035 IVUS to position the proximal aspect of the stent at just above the bifurcation. So we placed a 16 by 80 Abre stent, and after we placed this, we repeated the IVUS on the left side and noticed that we had about 4 to 5 centimeters of stent into the IVC. So we placed a second 16 by 80 Abre stent at the area of compression to ensure that we had good overlap, and these stents were then post-dilated with a 14 millimeter angioplasty balloon. This was our final IVUS from the left. So this is the stent in the IVC. This is the area of compression here, which is now patent, and that is just distal to the area of compression. Follow-up ultrasound at 1 month, you see that we have color flow within the stent, and our Doppler imaging is also showing that we have patent left iliac vein stents. The patient remained on Lovenox after this. So during this visit, we ended up having Our patient came back to clinic, had normal limb size, her lower extremity edema had completely resolved, had an extensive workup, which was all negative for any thrombophilia. She went on to have a successful delivery, and after delivery was on apixaban for DVT. So this was a provoked DVT due to prior mal-deployed May-Turner stent in pregnancy. So key learning points for the operator and team. In May-Turner, we want to ensure the stent is across the area of compression. IVUS is a powerful tool in the management of venous disease, and there's really limited data on long-term anticoagulation considerations in this complex patient population. And I would just like to thank my mentor, Dan Clare, for allowing me to do this case with him.
Great case, excellent presentation. Any questions from the panel?
I'm sorry, the indication for the procedure was edema?
Yeah, so she had appropriate therapeutic anticoagulation. So I think in this case, she would have failed anticoagulation and had significant left lower extremity pain and swelling in the setting of appropriate anticoagulation.
Pain and swelling. And how far away from delivery was she?
At this point, she was like 32, 33 weeks.
Okay.
So I got a question.
Yeah.
Why the choice of FlowTriever? That's sort of off-label for DVT. It's intended for PE, and it's a 24 French device. And a pregnant woman, it's already a risky procedure. Just kind of wondering what the idea was behind that.
I think your options for us in a case like this are, this is an acute clot. You want to make sure, I think it's much easier to get an acute clot out versus we've all had to deal with these stents that have chronic thrombus. I think what you get out of it at that point is actually much more challenging. I mean, there are only two options for mechanical thrombectomy, and this was pre the 16 French device with penumbra. In our hospital system, we didn't really have much of the 12 French penumbra device, so that would have been an option, or this 24 French FlowTriever device. I think we wanted to go with as much thrombectomy up front, so we didn't have to make as many passes to get as much clot out in one or two swipes as we could.
And then my second question is, the stent was previously placed when she wasn't pregnant. Now she is.
Yeah.
Obviously, she's got a large human being in her pelvis. Do you think that interaction may have created some additional scar tissue around the stent that led to that new area of compression, or no?
I don't think so. I think the reality was the first stent was mal-deployed. If it was across the area of compression, I think this would have been a very different outcome. I mean, these patients, we have patients like this all the time who go through successful pregnancies with or without prophylactic anticoagulation. I think in this case, it was a two-hit issue where you have misdeployed stent, and now she's pregnant. So this area of compression is even more significant.
I'd be curious. There we go. Your thoughts and the panel's thoughts as we think about iliac vein stenting in women of childbearing age, in particular.
Yeah.
So what do you think?
I mean, this stent was placed elsewhere previously. So I do think that we have to ensure the indications for these initial stents are appropriate. I know that there's a lot of kind of rogue stents being placed in patients who we find subsequent May-Turner, even without symptoms. I think their concern previously was that her initial DVT was not in the setting of pregnancy, and that whoever did it at the time thought that May-Turner seemed like a likely etiology for this.
What do you guys think? In a woman of childbearing age, a deep iliac vein stent because of that risk, what we see here?
So I personally don't stent young women at their iliacs unless they've had a pulmonary embolism. And before I stent any young woman's iliacs, I always have this discussion about pregnancy. Say, hey, are you planning for more pregnancies? That discussion I think needs to be had, because otherwise we are unfortunately faced with a situation like this where you're having to go in and kind of salvage this thing. So that's sort of my approach. And the second thing that kind of worries me is nobody knows how long these stents will stay open.
Right.
I mean, you put it in a 38-year-old. I mean, what if she lives to 80?
Right.
And how many more procedures and surgical options are sort of not great for failed endovascular therapy too, right? So.
I mean, I think even in this patient, figuring out what her anticoagulation strategy is going forward is actually going to be a very patient-centered discussion. If she were to get pregnant again, and even without being pregnant again, what is our anticoagulation strategy?
So I have to admit I have done in patients like this. So one of the patients I had was a 23-year-old post-pregnancy DVT, and I put on anticoagulation, and actually my anticoagulation regimen is Lovenox for 4 to 6 weeks. Then only I switched to PO NOACs. So this patient, I waited 6 months, and even the first time I put anticoagulation and then a little bit of echos, then she had severe obstruction at the left iliac, common iliac. So I had to do ballooning, then I put it, and she rethrombosed again. So she came back, and then I had to stent it.
Wonderful. Yeah, certainly great discussion, complex, thoughtful case, well delivered. So thank you so much.
Thank you.
All right, we'll be bringing up our next speaker, Amit Koduri, who's going to be speaking on a novel method to resolve lead-associated venous occlusion during EP procedures. All standard bread and butter stuff we're talking about, so this is great.
Hi, good morning. My name is Ahmed Koduri. I'm a first-year EP fellow representing McGovern Medical School at UT Health. Next slide, please. Okay, thanks. I have no disclosures. So we'll start right into it. Our case is an 88-year-old man who presents for VIV pacing upgrade. He's got half ref, 20%, stage C, NYHA class 3. His ECG revealed sinus rhythm with a left bundle branch block pattern, and he's got QRS 150 milliseconds. He has a previously placed primary prevention ICD back in 2016, and he had a prior venogram which found a left brachiocephalic venous occlusion at that time. Here's his baseline ECG, presenting in sinus rhythm. So this is the prior venogram which presents our clinical challenge. We did a left venogram of the upper extremity, and at that point we found retrograde filling up the left IJ, as well as 100% occlusion at the level of the left brachiocephalic vein. So we took this patient to the lab, and to do a VIV upgrade, we opened up the pocket on the left side, and the interventionalist on the right, CFV, gets access, and then tries to approach and cross this CTO with a 035 glide wire system. Unfortunately, we were unable to cross, and so we end up using a telescoping system consisting of a very long venous access sheath, a supercross, and an 014 coronary wire system. And we're ultimately able to get across. So as you can see, we've put a 014 fielder XT across and parked it into the left axillary vein after we've crossed the CTO. We've kind of inched over the microcatheter and then used that as a rail then to do serial balloon dilatations and plasting of the brachiocephalic and the left subclavian vein. And this is our post-venography. You can see there are multiple collaterals, but we have established flow. We've escalated the wire up to an 035 Amplatz wire. And then we have to kind of resolve a second clinical challenge. So the first clinical challenge was, how do we do the fibroplasty? The leads are parked inside of a vein that has chronically formed fibrous tissue adjacent to it. There are microchannels that we've been able to cross. And then the second channel is, after we do the plasty, we need the lumen to stay open long enough to facilitate, in this particular case, lead additions. And so this cartoon just adjacent to the slide kind of shows that progression of what we've done. And the bottom right-hand corner shows the axis of a Cook needle, which then puts a glide wire into the vein in order to maintain patency of the lumen. We call this the harpoon technique. So what you can see is the Cook needle is advanced from the pocket, contrast extracts out of the balloon, and a glide wire tip is advanced into the contrast injected balloon, making it sticky. And that is how we ensure patency of the lumen for access. And then this impregnated balloon is then dragged from the left brachiocephalic vein down to the right common femoral vein where we've gotten access as a flossing technique, and then that is used to facilitate access, and then we can later on get lead additions. This is our final result, where the patient has an upgrade to a bi-VICD, and then you can see the CRT therapy working on the ECG where the QRS complex is narrowed. So the key learnings for the operator and the team are patients with prior CIEDs and lead-related venous occlusions are procedural challenges to device upgrades. The case we present here is an innovative approach of, number one, crossing the chronic CTO using coronary wires, and number two, ensuring channel patency for lead addition via the harpoon technique. This procedure is safe and a reasonable alternative and can save patients the risks of additional pocket creation on the right side, lead tunneling from the right side, or lead extractions, which can cause issues to the vein. Thank you very much.
Very good. Thank you very much. Great case. Any questions from the panel?
So I have a question. So I have done few cases like this. So why do you have to keep this open? Because this is a chronically occluded. You just need a wire to upgrade to the bi-V. So one of the techniques I have used, went through the brachial vein, put a balloon across, pop into the balloon through the fluoroscopy, and put the wire in and get out. You don't need, I mean, this is a great technique, I'm not saying, but you don't need to keep it open because they are chronically occluded, but the only intention is to keep a wire to upgrade the bi-V pacemaker.
Correct. And I think the theory on that is maybe twofold. CTOs can form at multiple segments and sites. And so I think if you have a more proximal CTO, it could potentially be more prone to closing, and you don't really know if you plasty and then lose access, are you going to be able to get it back again? The second part of that is 100% CTOs may be different than a 99% or a 90% CTO, where there's already a channel there, and so it's more likely to stay open with the stretch, but 100% CTO may be more resistant to that. So that could be one of the concerns. I think the last concern is, oh, sure. Yeah, it's not going to be chronically open. Yeah, just enough for the procedure.
The point is that this isn't going to stay open.
Of course.
Yeah.
Yeah.
This is to
it's not even
facilitate
symptomatic.
lead placement. Yeah.
Mm-hmm.
So was the patient symptomatic? Like, did he have left arm edema?
No.
Because we see this actually in dialysis access patients where they have leads, or they have a chronic occlusion and they have edema in the arm, or their fistula stops working, and then you're trying to get these occlusions open and keep them open so that their access can stay open.
And that's a much different sort of pathology of how you get the occlusion, because that's an acute thrombus forming symptomatic closure of the fistula. This is a chronically lead-related occlusion, which actually doesn't form any obstruction because of collateralization that is formed around, and you can see that there's still flow, and so a patient won't have symptoms in these cases. It's just to facilitate lead addition.
I have a question, and maybe not necessarily for you, but does this complication go away with leadless pacemakers and devices in the future?
Yeah, leadless devices do not provide bi-V pacing support. There's potential for them to do conduction system pacing in the left bundle area. That is not ready for prime time yet, though.
All right, great. Great case and great discussion. Thank you.
Thank you so much,
We'll
everyone.
move on to our next case, which is presented by Dr. Kashayp.
Hi, good morning, everyone. I'm a third-year resident at North Alabama Medical Center. I'm presenting a case of endovascular stenting of collapsed IVC. So this patient had a very complicated and long history. I'd like to summarize it. It was a 75-year-old African-American male who was diagnosed with stage 4 leiomyosarcoma with mets to liver. He was on chemotherapy, as mentioned, trabectabine. And then he presented with complaints of shortness of breath. So labs on admission showed creatinine of 1.5 milligram per DL. Hemodynamically, he was stable. He was saturating 95% on room air. His troponins were initially less than 0.012, then increased to 0.217. On admission, patient received around 80 milligram Lovenox sub-acute 1 dose because ER thought they were dealing with something around end-STEMI. So this leiomyosarcoma was originally diagnosed in October 2019. And that time, CT scan abdomen showed mass inferior to spleen. Then he had PET, which showed liver lesions, and then he was started on chemotherapy. So prior to this hospital admission, patient had 2 to 3 ER visits and 1 admission, and every time he presented with abdominal swelling and increased swellings in the leg, and ER would just treat him with IV diuretics and some therapeutic paracentesis. They also did 2D echo prior to this visit, which showed ejection fraction of 60%. And they drained around 2 liters of ascitic fluid. CT abdomen was done without contrast because of AKI, and it showed hepatomegaly. So originally, when the CT abdomen was done, so the radiologist, he did not comment on IVC because patient did not receive contrast. So when this patient presented during this admission, my attending, Dr. Khan, he was going through the CT abdomen images from the previous admission. And then he noticed that patient had inadequate visualization of IVC. And then he thought that patient might have collapsed IVC. So CTHS was also done during this admission because ER wanted to rule out some pulmonary embolism. Again, it did not, pulmonary embolism was ruled out. So repeat echo was done this time, which EF was normal. So with high clinical suspicion of underlying IVC compression, which was diagnosed by the cardiologist, the radiologist didn't even mention it. So we had a discussion with ER and with the patient, and the patient was offered palliative stenting because the overall prognosis with the history of cancer and mets was, it was more than 6 months. So as mentioned, patient had IVC collapse secondary to intra-abdominal neoplasm, and patient was planned for IVC venographic imaging and possible stenting. So this is the IVC showing no evidence of thrombus. This is before the stenting. This is after the stenting. These are the images after the stent deployment. So a 60 mm into 150 mm self-expanding stent was deployed with adequate angiographic results with persistent no visualization of hepatic or renal veins, and patient had subsequent significant improvement in renal function and bilateral lower extremity swelling and scrotal edema. So this case highlights the diagnostic challenges of IVC compression, and endovascular revascularization can be offered for palliative purposes for refractory cases of advanced malignancy. And then patient was discharged home without any complications. If you guys want me to go back and do the images, because I still have time, I can.
No, so you said you're a,
Third-year resident internal medicine.
Congratulations on presenting this. It's certainly kind of
Thank you,
complex
thank you.
interventional therapies and important cases. In the multidisciplinary discussion with the cancer team, were they thinking just pure palliation with the filter, or was there some plan for targeting the malignancy, or did they think he was beyond the scope?
So he was already on chemotherapy, but I mean, not like hemodynamically he was stable, but like clinically patient was not doing really well. I mean, like, he was bedbound mostly because of the swelling that he had. His legs were huge. He was like bedridden for almost a year because of on and off hospital admissions. He was always short of breath at home, though he was saturating well at room air, but on exertion he would just become short of breath. So he was like, his quality of life was really poor.
I know there's a lot of expertise on the panel in IVC occlusion. Mazen, what do you think in terms of some of these tumor thrombus reconstructions?
So first of all, excellent case. I mean, this is a very, very tough situation, and you're not here to provide cure. You're here to provide quality of life, and that's the reason to do this. And so I totally understand. One quick comment. So you're going to do more of these in the future. Have less lines on your PowerPoint slides, because we can't really read that. Yeah. It's a lot, okay? No criticism, just saying in the future, okay? I definitely think you guys helped this particular patient, and I think your approach was perfect. One question I have, which stent did you use? Yes. You mentioned it was a 60 by 150.
Yes, so it was Medtronic Abre 16 mm into 150.
16, okay, perfect. Yeah. There's no 60 millimeter stent available that I'm aware of. Sorry. Maybe one day, but not as of yet. So I think from a technical standpoint, this was very prudent to do. You helped the patient. difficult situation. Obviously, nobody knows what the long-term results of these actually are. As you can see, there's a clear, decent pathway of collateral flow, but as the masses got large, it just was not enough to suffice. So, excellent presentation.
Thank you.
So the only thing I would recommend is 16 millimeter stent in the IVC. There is a high chance of distal embolization. I don't know the measurement.
But it's so compressed by the external compression. The space-occupying lesion in the abdomen will keep it in place.
That's scar tissue.
It's not on. Now it's on. Okay.
And that's an interesting point, because in folks you can treat for malignancy if you have time, you oftentimes try to initiate malignancy treatment to avoid that change in space and territory, and decide if you even need to do a stenting procedure. So, but wonderful job. Thank you very much.
And especially I would like to mention one thing, like I'm a resident and we see such patients all the time with ascites and lower leg swelling, and we as IM residents, we don't always consult cardiology, because our attending also feels that this is demand ischemia and STEMI, you don't need to consult cardiology, and the radiologists miss the IVC collapse. So I think my attending did a great job at going back, looking at the CT images, and then actually commenting on that. And he the moment patient arrived, within 3 to 4 hours, he knew what was going on.
Yeah.
Definitely.
Another quick question for you. What was your anticoagulation or antiplatelet regimen after stent placement? And then I'd like the panel to maybe talk about that a bit too. What did y'all decide to do for antiplatelets or anticoagulation?
So patient was started on aspirin and Plavix.
Okay. Yeah. Is that what you guys would do?
Well, so are we allowed to say it depends? Yeah, there's that great review, looking at a survey that was sent out to vascular interventionalists about what they would do in the setting of thrombotic or non-thrombotic deep vein, iliac vein, and there was 100 different answers. So if you could keep someone on anticoagulation for a period of time in this setting where there's questions of mixed tumor thrombus, I probably would try to do an anticoagulant plus an antiplatelet to start. And different focused answers in you guys, otherwise we'll keep going on to the next one. Well, thank you, our frontline internal medicine residents here at CVI. Great job, really great job.
Thank you for the opportunity. Thank you.
Next, we will welcome up Dr. Rahul Sawhney, speaking on intravascular ultrasound-guided bilateral vertebral artery intervention. I'm excited. This is going to be good. Let's hear it.
All right, thank you for having me. So my name is Rahul Sawhney, and I'm an interventional cardiology fellow at the Heart Hospital in Plano. And talking about IVUS-guided bilateral vertebral artery stenting, which is not as exotic as the other talks that we've seen so far this morning, but I'll try to keep it exciting. If I can make this work. Big green, there we go. I have no disclosures. The funny thing is I'm like the resident IT guy for my program, yet I can't figure out how to use the clicker. Anyway, so our case is a 71-year-old woman that had severe dizziness and near syncope every time she looked upward, and this was very, very reproducible on exam. Her pertinent CV history was notable for coronary disease with numerous previous PCIs, bilateral carotid stenosis that had been stented, CKD3B with a GFR of 33, and type 2 diabetes. So she had a lot of workup, including an echo, stress test, et cetera, and ultimately also had a carotid ultrasound and was told everything was fine. So her internal carotid velocities were normal and her vertebral velocities were normal. But she still had very, very, very classic symptoms and came to see us. So based on the symptoms, based on her vascular history, we elected to perform an angiogram. And this is what we see. So bilaterally, left and right, we can see there's about 90% stenoses in the origin of the vertebral arteries. And so given the discrepant findings, we also elected to perform IVUS. And I'm sorry, the images are not projecting as well as they were on the computer, but basically we can see that there's severe calcific stenosis bilaterally at the origin of these. So the clinical challenge here was that we have discrepant findings between the non-invasive study as well as the angiogram. The angiogram was pretty clear, but to confirm, again, we did IVUS and it was very, very clear. And this patient also had significant CKD that was limiting the amount of contrast that we could use. And again, IVUS is what kind of adjudicated that this was indeed severe bilateral stenosis and it was calcific in nature as well. So we elected to intervene and use IVUS to help us and minimize contrast use. So this is a lot of words. I'll show you the pictures in just a second. But essentially, we did bilateral scoring balloon angioplasty with 356 angiosculpt. And then we used a 4-5-12 and a 5-0-12 onyx stents, and then post-dilated both of them and had 0% residual stenosis confirmed with IVUS. So we can see that we have the balloon angioplasty happening here. And this is the old version of my slides, so I'm sorry, there's an issue with them, things not playing, and the updated version apparently didn't make it across. All right, sorry about that. My final slides are not projecting there, but I can tell you that there's 0% residual, and the IVUS showed that the stent was well opposed, well expanded, without edge dissections, and mainly we used only 20 cc's of contrast for the whole intervention. So on follow-up, her dizziness resolved within a few days, and then at 6-week follow-up, she had no further dizziness, no further near syncope, or evidence of any procedural complications. So the key learning points from this case were don't ignore symptoms just because initial testing is normal. Her referring was ready to kind of write her off and say, you have a lot of reasons that you could be dizzy, but based on the classic story, that's what really bought her the angiogram and ultimately got her the fix. Consider IVUS to adjudicate discrepant diagnostic findings, and size, measure, optimize to minimize your contrast use. And ultra-low contrast PCI principles that we adopt in the coronaries are pertinent in the peripheral world as well. Thank you.
Great case. Thank you very much, and great presentation. Kind of an obvious question. Why treat both vertebrals? Like, that's the one system in the body where you have, like, you could fix one and presumably fix the intracranial circulation. So why do both?
That's a good question, and we kind of vacillated about that. Given her vascular history, given the fact that all of her coronaries had stents, both of her carotids had stents, it was hard to determine which of the vertebrals was dominant as well. So we elected essentially, and based on her CKD, all that stuff, we wanted to minimize bringing her back to the cath lab. So we fixed one, it looked good. We were satisfied that even if we screwed up the second one, the first one would continue to supply her, so we elected to fix both.
An operator's enclave question, which maybe was discussed, and maybe the panel has thoughts. Use of embolic protection in vertebral artery cases. Is that something that was discussed, or something maybe not routinely done by your team?
It was discussed. I mean, carotids, of course, we use it. Vein graft intervention, we use it. So it was discussed, and ultimately, based on the IVUS imaging, decided that we were going to do a scoring balloon. We thought that the risk of distal embolization was low, and so elected to proceed without it. But we did consider it.
What does the panel think for vertebral arteries? I mean, this was a perfect case, a perfect indication, and really severe disease, well performed. Any takers for EPDs and vertebral arteries?
This is a little bit scary, as you guys have bigger guts than other people. I'll tell you, just listening to this makes me a little bit nervous and worried. Not that I'm a big expert, but we have multiple panels when you have vertebral stenosis, like multi-speciality neurosurgeon gets involved at the Cleveland Clinic, neurointervention guys get involved, vascular surgery, and I get involved. Then we come to a consensus which patient should be treated. Why we worry about this is, I agree with the chair people here, it's a little bit cavalier to fix both. You don't need it both. You figure it out by dominant circulation, looking at the IVUS. Don't worry about the contrast. Give a little bit contrast, get a good picture. In fact, we get a complete cerebral circulation, make sure that everything is intact, make sure where the connections are, and then do the procedure. You would have noted if you had bilateral carotid stenting at some point, you had circle of Willis. Based on that, you could figure out, just fix the dominant circulation. Second thing, distal protection is important, but be careful putting distal protection higher up. You get spinal arteries coming out, and you embolize a spinal artery, or even doing a scoring balloon. I never heard of anybody doing scoring balloon or cutting balloon in the ostium or the vertebral. If you dissect up, you get what is called as the man in a barrel syndrome. The person will be straight like this, and he'll be wide awake, alert. He cannot move anything, neck down. Don't do it your worst enemy for that, because that's really the terrible one. So the reason why we're very careful is, despite all of this, I had a 76-year-old guy. We recently, after getting everything taken care, and we fixed this, and patient went home, he came back, and he just couldn't lift his right arm. We get an MRI of the brain, clean, and I'm trying to wash it off and saying it's crazy, nothing before this. Then my neurosurgeon said, no, get a cervical spine MRI. We get it, he has a spinal infarct. And I was telling them, he still comes to my clinic. I feel terrible. The guy was walking around before, he can't lift his arm. So we do a lot of disservice with these things. Nobody died because they couldn't lift their head up. just think about these things, because you guys got really lucky, but just makes me nervous just listening to it.
Point well taken. Thank you.
Any other questions? I think actually really good case. One thing whenever you're doing these cerebral vascular interventions, it's good to have a picture of the circle of Willis. So either a CTA or an MRA or something that can help you, because this person could have some anomaly where the vertebrals don't join, or like whatever. There's so many, or like they have a fetal PCA or whatever. But it's good to know what you have in the head before you go into these. But great case, great presentation, and we'll move on to the next one. Thank you.
Yeah, Rahul, just one last question. One last comment. If nothing else, a cerebral perfusion scan can be very helpful as well. I know contrast is always of concern, but if there's a concern of what the diagnosis actually is, that oftentimes does help quite a bit.
Just kind of like the stroke protocol perfusion.
Exactly.
Very good. Thank you.
Thank you. All right, we'll have our next speaker, Dr. Miller.
Thank you very much for inviting me to participate in your Endovascular Challenge competition here. So I want to present a case to you. It's a unusual case of chronic limb ischemia. I've been in practice since 1987. I've been doing endovascular work since '89, and I've never seen this case. So we'll see what you guys think when I present it and how I treated it. So this is an 82-year-old female with a non-healing wound of her right heel. She was referred to our institution because she had been bedridden for several weeks following vulvar surgery for squamous cell cancer and had developed a decubitus wound on her right heel that was not healing and had become so painful that she was requiring narcotics around the clock. She had type 2 diabetes mellitus with stage 4 CKD. You can see her renal chemistries there. And again, she did not have complete treatment for her carcinoma of the vulva. So this is her right heel wound, and notably, she's got necrosis of her calcaneus bone here, and you can understand why she would be having pain at rest. So with her chronic kidney disease, I decided to, I did, by the way, a non-invasive assessment I'm not showing for lack of time, but I decided to go up and over with a straight flush catheter, and my technique with CKD is to take 2 cc's of contrast, dilute it to 6 cc's, squirt it as hard as you can, and take 6 frames per second. So you get a relatively good image on these studies. So there's her proximal SFA with moderate disease. And then her middle segment of the SFA, I'll show you more clearly later, but you can see there's a filling defect in the middle of the SFA. And then if you look closely, you can see there's pretty dramatic venous return fairly early in the angiogram. Further downstream at the popliteal area, you can see why. She's got a nest of AV malformations there at the P1 segment of the popliteal artery. But if you look a little more carefully, you can see there's another draining vein coming up from below at the very end of this injection. And so I brought my straight flush catheter down right at that middle segment of the SFA to better visualize this lesion of the SFA. It was calcified, and I used a little 018 gold glide wire to get around it and to advance my straight flush further downstream so I could again get good visualization downstream. And this is her trifurcation vessel system, and you can see the duplicated perineal vein is very large, and in fact, the perineal artery itself is very large. And then further downstream, you'll see why. She's got this big collection of AVMs down in the mid-calf. And down at her ankle level, I brought, this time I took a Trailblazer 18 down, and you can see that the blood flow to the heel area is very marginal. And of course, I'm injecting right at the spot here beyond most of the AVMs to try to visualize what the blood flow is to the heel. But you can imagine how much steal is occurring at this level of her leg. So that was my diagnostic study, and I decided to consult a few of my consultants or my colleagues. And so an interventional radiologist said, well, one thing we could do is try to embolize the major AVMs with some type of a coiling system. He said, but likely we won't get them all because there's such a wide variety of sizes there. A vascular surgeon said, well, I could cut down on the popliteal vein and then slip a coil up there and occlude the popliteal vein above where the AVMs are. But when I told this to the radiologist, he said, well, the AVMs are just going to find a new route to drain, so I wouldn't go that route. And then the orthopedic surgeon said, well, I can do a below-the-knee amputation. That'll take care of the problem. But we thought that would be our last choice. And so my decision was to go a different way. So the first thing I did is I put in an embolic protection device that's right here. And then I did intraarterial lithotripsy to treat that calcified lesion in the SFA. And I was kind of hoping I'd be able to kind of smash up the AVMs and maybe seal it that way, but that didn't work. And then I used an angiosculpt to further expand the SFA because the lithoplasty device didn't really get the lumen as large as I wanted. And this is post-cutting balloon angioplasty with a nice flow down to the popliteal artery where the first AVM is. So then I inserted a Viabond covered stent. I used a 5x10. Make sure you don't use the Viabond BX because those will kink with those little wire rings. So this is the plain Viabond, and this is the result after the Viabond. And now we're going to go down to the perineal artery here. And so I made the decision to kind of go off-label here. And so what I ended up doing is first getting a good look at where the draining vein, or where the artery was to the heel. And I chose a papyrus covered stent system. This is a polyurethane woven stent that's a covered stent we use in the coronary world when there's a coronary artery perforation. This is off-label use, so I did contact our IRB and told them my plan, and they said, well, okay, but expect a few papers to sign when you're done. So what I did is I first deployed the first papyrus stent, and then I deployed a second one, and then a third one. And I'm thinking, God, I hope this thing will seal, and then it did. So essentially sealed, there's just a little bit of a leak left, but what was most impressive is the blood flow to the heel. You can see excellent blood flow to the calcaneal area and a nice blush of where the wound is. So I felt like I had accomplished what I'd set out to do. She still had pain in her heel, but the pain was dramatically better. And that's the end of my report.
So, Viabond behind the knee. You know, we talk about it a lot now in kind of novel treatments for popliteal aneurysms. What was your kind of decision making or risk stratification there? And I'd love to hear from some of the surgeons on the table too for Viabond placement in P2, P3.
Excellent question. So this was basically a palliative procedure for a patient with resting pain. This is not something I routinely do. And I have put Viabonds in the past, and one of the things about Viabonds, the regular Viabond behind the knee especially, is when you bend your knee and straighten it out, the Viabond really doesn't anchor. And so what happens is it kind of pistons up and down, and you get that candy wrapper stenosis there if you put it at that location. So if I have to put a Viabond in behind the knee because of a popliteal artery aneurysm that is embolizing, what I often will do is then line the Viabond with a Sapera inside of it to anchor it on both directions so that when you do bend the knee, you don't get that pistoning effect that causes the candy wrapper stenosis.
This is a cool case, actually. And thank you for presenting this. So I actually have seen quite a few of these, and typically in this patient population, non-ESRD CKD patients with type 2 diabetes. I just want to know, when did you place this stent and what's the follow-up?
So I wished I could have shown the last picture, but my last picture was a picture of the heel, nice and pink, 6 weeks out. So that was from the wound clinic. They said that she's beginning to heal and the calcaneus bone looks very healthy. Yeah. And they were planning to do a skin graft in the future. Because
I'll tell you, in my experience, they sprout more AVMs in the non-covered stent areas. So if you actually look at the last angiogram of the heel, you see the arterial inflow, but there's a little AV malformation. There's early venous filling there. This is some sort of predilection for developing these things. So unless there's a real good indication like a bad heel also like this and the patient's facing a BKA, I have actually shied away from fixing these because they just come back and much more aggressively. So I don't know what the panel has seen, but I've at least seen about 5 or 6 of these cases. And the last 4, I don't think I've treated them at all because I didn't feel like I needed to. You know, the first 2 I did, and when I repeated the angiograms, I saw they just come back with a fury.
Yeah. I would agree with you. I've never seen it in this setting of tissue loss, and I think for this particular case, given the options that were available, your choice was probably the best choice. Surgical options for this are very limited and often are fraught with severe complications, particularly bleeding. You think that's 1 or 2 or 3 or 4 veins, but it's not. It's a network, and operating on something like this would be a disaster. So I applaud you. I think you picked the right decision for this particular patient.
Any tips or tricks for making sure that you're covering the segment you want to cover and not missing?
Yes, so I didn't show those pictures too, but what I did before I actually deployed my first papyrus is I took a balloon down and I did what's called a balloon occlusion angiogram. And so I picked a balloon that was 20 millimeters in length and blew it up, and then I injected from above and then repositioned the balloon to try to get an idea where exactly am I going to need to position these covered stents. So didn't have time.
No, it's great, and you know, it'll if you're proximally occlusive and there's distal change, it's tough to see. One of the things you can do is, at least through a 7 French system, you can slip an 018 microcatheter next to your balloon. You can balloon occlude and then take a picture distally through that 018 and get a sense if you're missing something beyond. Because it's a great example of how much of a quagmire these things are. I can't imagine coiling or plugging any of that. It's just a spider web. So great case. Thank you so much.
Thanks for inviting me.
So we do end up trying to coil these things, but I'm glad you didn't go down that rabbit hole, because some of them, as they mentioned, it was not like in a setting of an acute limb ischemia or a chronic. We used to do them a lot of embolization, and my mentor used to say, in India, when a man gets married, he gets money from the women called dowry. He said, if you start to treat the fistula, you don't need a dowry, it keeps coming back, because they keep on coming back so much that it becomes annoying. But since you're in a Colorado area, I can tell you in Salt Lake City, there's a guy called J.J. Emboman. I think his name is Joby Joseph. They call him the Emboman because he works with Cook. He's one of the masters of this AV fistula. If you contact him, he'll come and proctor you. He goes into that nidus, both proximal and distal, and he'll take out the nidus and he'll take care of the fistula very nicely. But it requires a lot of contrast, and to get him is like difficult, but he's the really best guy. If you contact Cook, they know his information.
All right, thank you very much.
I might lastly talk about my anticoagulation strategy, because she had chronic kidney disease, so I used a reduced dose of apixaban 2.5 twice a day and some clopidogrel.
Very good. Thank you so much. And next, we'll welcome to the podium Dr. Ahmed Abdelwahab, speaking on injury of the superficial femoral artery and posterior tibial artery associated with an atherectomy device. Thank you so much.
I am Ahmed from University of Toledo, research fellow, presenting this interesting case with no disclosures. A 57-year-old male with critical limb ischemia and an ulcer. The patient was a smoker and he was not diabetic. So when we done the angiogram, we found there is occlusion of the superficial femoral, SFA, and the popliteal artery. So we prepared the patient to make atherectomy. During the procedure, we noticed that the atherectomy device suction of the wire, and we cannot proceed and advance the wire. So this was a challenge during the procedure. So this is the wire. So what's the resolutions, or what we should do during this procedure for the patient? We done approaching of the wire, V-band covered stent of the SFA, and long balloon angioplasty of the posterior tibial artery. This is after. So what is the key learning points from this case? So during the procedure, we can expect to happen this with the atherectomy device, careful removal of the broken wire, and vascular injury can happen. So after that, we reported the problem with the atherectomy device for the MDR. The patient presented to our clinic for the vascular clinic after the procedure. He was healing, improving the symptoms, and he's better. Thank you, and especially I want to acknowledge my mentor, Professor Munir Nazal, for giving me this opportunity to present the case. Thank you.
Thank you very much. That was a good presentation with an interesting case. These device complications are always, causing arrhythmias when they happen. Maybe for the patient, but definitely for the operator. So which atherectomy device were you using?
We was using Rotarex device.
Right. And it was a little unclear to me what happened. Do you think the wire broke and then you had like a fragment of retained wire? So can you just sort of explain that maybe?
So we are expecting that to happen. The wire was broken and suctioned we cannot advance it. So we're expecting this. We cannot definitely say it's 100% that happened, but we'd expect that. I reviewed the MDR retrospectively for reporting incidents happened with the same Rotarex. I found that several cases was reported during the last 10 years this.
Right, so when you it looked like you could get the device out. So could you see sometimes when you get these devices out, you look at it and like a piece of it is missing, or you look at it and you see the wire, not all the wire came out. So how did you know that there was a piece of retained wire? Because it's good that you find it. Sometimes you go and do a CAT scan later on, and then you find the retained device. So how did you know that this piece was missing?
It's a good point. I couldn't make sure.
Quick question. What was the indication for the procedure?
So the occlusion, what happened for the artery SFA.
Yeah, but what were his symptoms?
Ulcer, critical limb ischemia, and the patient having also ulcer in his foot.
Ulcer on the foot?
Yeah.
Okay. Did you guys atherectomize in the posterior tibial?
No, we did only the SFA, and this happened when
in the posterior tibial. That's odd. That's really odd.
Injury.
Wow.
So this is during the suction, the injury happened to the posterior tibial artery.
Any tips or tricks from frequent Rotarex users? I don't use a ton about. Nope. Okay, another comment.
No, I don't use Rotarex, but I have, this is more than what we think. This Avenger TurboHawk devices, they can cut the media, normal media, and in the future, especially if you're doing DCB and not using a stent, they can come back with aneurysms in that same segment. It is not clinically significant many times, but it is not more common than we think.
Thank you.
Certainly being thoughtful and careful with use of atherectomy devices, loading atherectomy devices on wires, and most commonly, and I don't use a lot of Rotarex, slow, organized cutting, and knowing that if you feel like you're grinding against an unmoving object, being thoughtful about what the next steps are. It's different for every device along the way.
So I've probably done, 350 or 400 Rotarex cases in my experience. I've honestly never have seen this complication before, but I've certainly heard of the device itself unraveling from over torque. And typically what happens in that scenario is it'll seize on the wire, and when you go to remove it, you have to remove the entire device. But I've honestly never seen it whip the wire around to the point where it's going to injure a distal vessel. So that's pretty unique, and I'm glad that you guys reported that because people need to be aware that that can happen.
Yeah, if you went to the website, the MDR, it's publicly and FDA regulated.
Yeah.
So you can find every reporting incidents happened to the Rotarex device in the previous whatever period you can do. I did retrospectively for 10 years. I find like 5 cases have been reported during this. It gives you some information about the hospital and what happened and the injury of the vessels. So I think we need to publish like a retrospective from this MDR, because MDR, it's mandatory for the hospital to report it. There's other FDA-regulated website, but it's voluntarily. But if you've done Rotarex problem, you have to report it to FDA.
Yeah, you do. And one other key point is if it's an occlusion and it's heavily calcified, I have found myself having to sometimes pre-dilate just to perform atherectomy. And I know that sounds silly, because what's the point of atherectomy at that point? But the diameter of the device is, I believe, 3.2 millimeters in diameter. I could be wrong about that, but maybe, or 2.4. 2.4. So you just, but there is two sizes. There's a 6 French, there's an 8 French. So for SFAs, I typically use the 8 French device, and for, you know, popliteal, smaller vessels, 6 French. I would just say sometimes ballooning prior to atherectomy sometimes can help.
Yes.
Yeah. Yeah, same experience, yeah.
So 2 millimeter we used actually.
Yeah.
So if you overdilate, what's the point of putting?
Absolutely, yeah, I agree. Wow, tough case.
Yep, tough case,
Yeah.
tough case. Thank you very much
Thank you.
for presenting that. Very good. Okay, so we'll get to our next presenter will be Dr. Alghammass. Alghammass, sorry.
Hello, everyone, and thanks for having me today. My name is Mohammed Alghammass. I'm a second year general cardiology fellow at University Hospitals in Cleveland, Ohio. I'm presenting today a peripheral case about deep vein arterialization. All right, no disclosures for this case. Essentially, this is a 73 years old male who was referred for a second opinion on revascularization. His presenting symptoms as essentially severe wrist lift leg pain. His pertinent history included PAD with chronic limb ischemia and remote stents 10 years ago. He also had a CAD and had cabbage for that. He also had multiple other peripheral vascular disease issues. So essentially, his history started in November 22 when he started to have left heel ulcer. And after that, he got investigated in an outside hospital, ended up getting a left femoral anterior tibial bypass in December. However, his wounds weren't healing as expected, and he developed multiple toes ulcers. In March, he underwent also a PTA of the same bypass and the native anterior tibial. However, he continued to have severe wrist pain. Eventually, he presented to our hospital on April 16th, and this is his presentation pictures. As you can see, kind of worsening toes ulcers there and heel ulcers. So on the 17th, we took him to the lab, and he underwent a successful IFAS guided revascularization using a self-expanding stent to the distal left common iliac and drug-coated balloon to the left common femoral. This was a staged procedure, so the next day he went for a left superficial femoral CT auriculation with stenting a PTA. He also had a left popliteal drug-coated balloon and left anterior tibial recanalization with a PTA. Following this, he stayed in the hospital for a week, and he continued to complain of pain, wrist pain essentially, and his wounds weren't healing despite these revascularization. So he was re-evaluated with our endovascular team, and this decision kind of was difficult because this was at this point is a clinical challenging case. There was no surgical option except essentially amputation, and the attempted endovascular revascularization were unsuccessful. Upon starting the case, this was an extremely difficult lateral planar vein access, and we were also surprised to find a totally occluded SFA, which was recently revascularized. So the case started here, and eventually, in the beginning, there was multiple trials to access the left planar vein, essentially lateral planar vein. However, it was difficult to access the diminutive ultrasound and the fluoroscopy. So, in the first picture here, you can see that there's the access to the greater saphenous vein with the hand injection phenography. However, we couldn't really visualize the lateral planar vein despite multiple views, despite also using a microcatheter. So eventually we went ahead and gained an access to the left posterior vein with a micro-access catheter also, and you can see there's some patency in the left lateral planar vein on the picture on the right side. So after that, when we gained access to the left posterior vein, we advanced a 0.14 pilot 200 wire, and it was lifted in place essentially to guide an access through the planar surface to the left lateral planar vein. And this was done sequentially with a micro wire, which was placed in a retrograde fashion in the middle picture there, and into the posterior tibial vein. This allowed us to, let me see. I want to go back. Sorry, Sorry. So eventually this allowed us to put a 4 French sheath, and the selective phonography on the right side of the picture showed that the patient had a patent left lateral planar vein, and also he had 2 posterior tibial veins, which both were patent up the leg. After that, we gained an access to the femoral artery, and this was surprising, which showed essentially the SFA stent were completely occluded, as you see in the left picture. Right-sided access was gained after that, just to kind of analyze what's happening, and it showed that the common femoral artery was open. However, the SFA stents were occluded. The provanda was open. However, there was no distal runoff. So decision at this point was to proceed with the JEDI percutaneous thrombectomy. As you can see here, there was multiple runs, and then the post-JEDI thrombectomy flow there was good in the superficial femoral artery and the provanda. After that, we performed ballooning with essentially a compliant balloon on the left-sided pictures. And then there was 2 stents placed, one in the proximal aluvia 6x40 in the proximal SFA to include the ostium and the provanda, and then the distal, which was supra stent to include the distal part of the SFA with the popliteal artery. And there was a good flow essentially across.
Guys, he lost his slides.
I think that was the end of the time. So what happened briefly?
So essentially, we proceeded again with stenting the area, and after that, the next slide is the most important step, which is the percutaneous arteriovenous bypass through the tibial peroneal trunk, through the posterior tibial vein, so as you can see in the left picture there, this slide actually. We crossed through the tibial peroneal trunk to the posterior tibial vein, and then that created an arteriovenous bypass, essentially. We dilated and essentially got a phenography of the leg, which showed a patent, essentially blood vessels in the leg. After that, we went ahead and did a Viaban across that arteriovenous bypass. And eventually, this patient came back for a follow-up in 6 weeks, and I have pictures actually for his essentially ABI, and he had a very good flow in the distal lateral planar vein. And there was essentially, the last picture was his healing process. I just talked to him last week. He denied any pain. He did very well actually, and his wound ulcer was healing at that point without any pain.
Very good. Thank you very much. Great case. Any questions from the panel?
Great case, complex case, very well presented. It's a nice little surprise to have an SFA occlusion in the middle of a DVA case. Follow-up of these DVA cases is tough. You know, you get this post-procedural edema, these changes that happen. This is even more complicated because you're fixing an SFA that effectively intervention that had failed, that you had to redo. How are you watching this person after?
So he is currently actually following every 2 weeks with the wound clinic, and we're getting pictures uploaded to the system, and the endovascular interventionalist is following him also.
And then there's this next thing to think about. You know, we know so little about kind of tissue perfusion, where there were some tools that were being kicked around for it. How did you decide to just not fix the SFA and think maybe that was enough? You know, maybe this didn't heal because the SFA went down.
It was actually fixed at that point with 2 stents across the SFA and the popliteal artery, and then dilated, and there was a good flow across the SFA.
Yeah, no, I just meant in terms of sequential thinking. And you can make the argument it was fixed once, it didn't heal, it got worse, so we decided we had to fix everything.
I guess the decision was made just to support the distal flow through the arteriovenous bypass.
Very interesting case and kind of complicated. I guess I don't understand what happened to the bypass. Didn't the patient initially had a tibial bypass that it sounded like they tried to salvage for a little while, and then it occluded?
Yes, it's occluded.
Okay.
Yes.
And then it sounded like maybe the SFA first intervention went down because there was no outflow.
Yes.
Was this concurrent with the recanalization of the AT?
Yes.
So how did you pick where to do the DVA? Like where to make
So-
the fistula?
So essentially, the first to try was actually to try the posterior tibial artery because there was a very good flow and there was proximity between the artery and the vein. However, they tried multiple times essentially to cross the posterior tibial and it was also occluded. So the best next spot was the posterior tibial trunk, and that was a very good spot to cross to the vein essentially.
Questions? Okay, very good case, very tough case. These cases were like, you know.
Wish I showed the pictures, they were amazing.
Okay, very good. Thank you very much.
Thank you.
All right, we're gonna try to stay on time. Everyone has to go to lunch. Our next speaker will be Dr. Feroz.
So is a green button to move forward? All right. Hello, everyone. My name is Rafi Feroz. I'm a third-year general cardiology fellow at Cleveland Medical Center in Ohio. I have no disclosures. So the case we're talking about today was a 58-year-old male with a past medical history of end-stage renal disease, for which he was on dialysis. He had also had a CABG, PCI ×4, and heart failure with a CRTD that had been placed in the past. And 5 months before this case, he underwent a heart and kidney transplant. Unfortunately, his renal graft failed and he had to go back on dialysis, but the heart transplant worked reasonably well. Unfortunately, after the heart transplant, he developed persistent left upper extremity and facial swelling, and he was found to have DVTs and placed on anticoagulation. Over time, the facial swelling improved, but he developed bilateral upper extremity swelling despite anticoagulation. A repeat venous duplex was done, which showed significant DVT burden in the superficial and deep veins of the arms. And this is a picture from those series of images. And this is a Doppler of the right IJ showing continuous flow suggestive of outflow obstruction. And something not shown here is that an MRV was also done, which was overall inconclusive, but raised some concern for SVC obstruction. So the plan was made to start with an angiogram to see if there truly was SVC occlusion that could be intervened upon. So initially, right femoral access was obtained, and a multipurpose catheter was placed in the SVC. And in this venogram, we see that there's distal SVC occlusion. So in order to tackle this, the plan was made to get access from the other side as well. Concomitant brachial vein access was attempted, but was unsuccessful. And then right IJ access was attempted. So in these images, you can see a wire coming down from the right IJ and then a wire in the SVC. But the way the wire was behaving as it was being advanced, and just in the third image, where we take a cine as we rotate the II, the right IJ wire and the wire in the SVC don't appear to be in the same place. So there was concern that these wires are not meeting in the same location. And then another venogram from up above showed the opacification of a linear structure as opposed to opacification of the right atrium, suggesting that right IJ wire was either in the azygous vein or a left internal mammary vein, but not going into the SVC and into the right atrium. So then we abandoned right IJ access and went to the left IJ, and there we discovered a left brachiocephalic vein occlusion. In this angiogram, you also see a trialysis catheter, which the patient had from before, going from the left IJ into the SVC. So accessing the left subclavian was a challenge, but ultimately with the combination of a Navicross microcatheter and a stiff angle glide wire, which is a hydrophilic wire, by sequential movements of using both of these with the Navicross to provide support, we were able to gain access to the left brachiocephalic vein. And then once the stiff angle glide from the left IJ was close to the SVC, a snare was used to externalize the stiff angle glide, which is shown on the image towards the right here. After that, the stiff angle glide was exchanged for a steel core wire and then advanced from the right femoral to the SVC and towards the left IJ. And that allowed us to put a intravascular imaging catheter here, in this case we chose IVUS, to get a rough idea of vessel size. And the IVUS here showed significant thrombus in the SVC and the left brachiocephalic. After that, angioplasty was attempted with compliant balloons, and I believe we chose a 3 millimeter balloon first, and then upsized to 6 and then 8, and they were inflated to about 6 to 8 atmospheres. And here is an angiogram from the right IJ showing flow of contrast between the right IJ and the left, between the SVC and left brachiocephalic vein, and then also there's a pacification of the right atrium and pulmonary artery, suggesting a reestablishment of some venous outflow. So within 3 months, the patient had almost complete resolution of his upper extremity swelling, and he was in fact admitted 2 weeks ago for unrelated reasons, and he felt like there was almost no swelling at all, and his arms had gone back to baseline. So some key points to take away from this case are that for this left brachiocephalic vein angioplasty and sort of SVC angioplasty, proximal and distal access was needed, very similar to peripheral arterial cases like the one presented right before me, where antegrade and retrograde access is sometimes required. Getting through that left brachiocephalic occlusion was challenging, but the combination of a microcatheter for support and a hydrophilic wire was able to accomplish that. And then we used a snare to connect the proximal and distal access points. And then after externalization of the wire, we were able to use a stiffer wire for delivery of balloons and intravascular imaging. And with that, I will take any questions.
So it's a great case. So I have the same case, and I was just talking about it like 30 minutes ago. So I've got like 10 questions, but I'll try not to dominate time. What do you think happened? Why do you think he had this?
So, before his heart transplant, I think he'd had multiple right heart caths, multiple central lines, dialysis catheters placed, and the combination of all of those probably resulted in a DVT, which him being in the hospital just got worse and worse, resulting in
And then the next question that comes up is, so why don't you stent it? Or did you think about stenting it?
Yeah.
It wasn't perfect at the end, right? But there was enough flow that the symptoms went away. Did you guys talk about it?
Yeah, so I think one of the potential barriers to stenting was that there was a trialysis catheter there. And because this post-transplant patient was going to have significant transient venous accesses for biopsies, we didn't want to try to put a trialysis line in his femorals, so we wanted to not mess with a trialysis line that was working well. And for that reason, the goal was to see how this angioplasty works and if it reestablishes flow to get rid of his symptoms, which it did.
Yeah. So that trialysis catheter actually probably was a friend to you in many ways, and
Yeah.
I actually would have used that to cross because it was already crossed.
Yeah.
And there's no harm in crossing, snaring from below, using that trialysis catheter, and then at the end of the case reinsert it because you're already across. I think it would have made your case a little bit easier. Along those same lines, if you decided you wanted to stent, you could do so, and then again replace the trialysis catheter at the end of the case.
Yeah.
But I also agree that there's a lot of variable questions here, and not doing it initially is probably okay. My suspicion is this is also a surgical anastomosis, which is another issue as well.
So, thoughts?
Yeah, we did discuss that part of the SVC occlusion may be from a suture line. With that being said, if I think if he came back with persistent symptoms, then stenting would definitely be on the table.
Sure.
You can tell Mazen and I worked together for a while. So our case was the same thing. So we had the same case. Someone came in, it was about 1.5 years after a heart transplant, upper extremity facial swelling, wired it, actually came in from the basilic vein, got across it, IVUSed it, and very clearly you could see kind of an anastomotic stricture and then filled with clots. So we ballooned it. She had pain when we ballooned it, which is somewhat terrifying. Symptoms improved. Thing came back again. So we talked to cardiac surgery. They were scared about doing it. We ballooned it again, got a cardiac MRI, and this is very clearly a surgical anastomosis. When the heart was sewed in, it was just sewed in in a way where it was just tethered or tightened. And so as a result, it just kept rethrombosing even on anticoagulation. Okay. We ended up sending her for a surgical revision because there was this fear of getting a stent anywhere near size. Because even when we had a balloon to size, at low pressure, when the part across the stricture was starting to balloon, she just felt it tearing open. Okay. And so she had a surgical revision, and now that was 3 years ago. So great case.
Good case, yeah.
Thank you. I actually also have the next case. So.
Oh, there you go. We would like to introduce to the stadium.
All right. So I've already introduced myself. So our next case is a massive pulmonary embolism. Again, I have no disclosures. So this time we had a 28-year-old female who had a history of a provoked right IJ thrombus 5 months ago. And the provoking factor for this right IJ thrombus was tonsillitis. She was placed on anticoagulation for 3 months, but then developed tonsillitis again and was placed on antibiotics. She ended up coming in with respiratory distress and syncope, and she was intubated in the ER and then transferred to our medical ICU. There, unfortunately, she developed a pressor requirement, a worsening oxygenation, and a CTPE was done. So here on the axial views, we'll be able to see significant clot burden in the right and left main PAs, and the coronal view also shows that. And if you look at the axial view, I'm going to let it play out. There's a significant dilation of the right ventricle with clear RV strain. I believe the RV to LV ratio here was 2.3. Here was a echo done the same day, which shows moderate to severe TR with an RVSP of 61. I didn't show these images for the sake of time, but there was severe RV dilation with severely reduced RV function. So in the medical ICU, before she was started on pressors, her blood pressure was 66/42 with a heart rate of 114, and she was on a ventilator. Significant labs were that she was acidotic to 7.19, had a neo AKI at 2.02, leukocytosis at 21.2, and then biomarkers suggestive of RV strain. Her lactate was 2.1. Her PESI and BOVA scores were elevated, suggesting a high-risk PE, and because she required pressors, this would be classified as a massive PE. Before I go into this angiogram, there was a PERT team discussion about the best approach. While she was quite sick, not severe enough to the point where we thought she needed systemic TPA. So the plan was made to pursue a catheter-based intervention, but given her instability, hemodynamic instability, the PERT team decided to do this with the combination of ECMO. So the left femoral artery and vein were cannulated for ECMO, and then the right femoral vein was cannulated for the procedure. On the right here, we have a pulmonary angiogram, which shows significantly reduced flow bilaterally. For intervention for this, the Inari flow retriever device was chosen to provide large bore thrombectomy. And ultimately, the way this works is that we initially use a soft wire and a GR4 catheter to get to the right place. Once we have enough wire purchase and the GR4 is advanced, we replace it with a stiffer Amplatz wire, and then the thrombectomy catheter is advanced to the area of clot, which on the image to the left is in the right main PA, and then aspiration is done, and then the steps are essentially repeated in a different portion of the pulmonary vasculature. This is the clot that was removed. Her RA pressure improved from 15 to 9. Her PA pressures also decreased, and her cardiac output was 5.9, and cardiac index was 3.3, but this was on ECMO. She was transferred after this to our cardiothoracic ICU. She was placed on a little bit of epinephrine and some inhaled epoprostenol, but ECMO was eventually discannulated the day following this procedure. She was extubated 2 days after this procedure and then sent to the floor 4 days after that. These are her surface echo images showing a significantly reduced, basically a normal RV with normal size and normal function, and her TAP-C and S prime were normal, suggesting her RV function had improved, and she had trace residual TR. So some key points to take away from this case are that as catheter-based procedures for pulmonary emboli are becoming more common, a potential barrier that comes up is when people are significantly hemodynamically unstable. It's a little scary to take them to the cath lab without some form of additional hemodynamic support. And concomitant ECMO is something to think about before attempting this procedure.
Tell us about the ECMO thought process. So you're standing there in front of a high-risk PE. You're deciding in this 38-year-old, do you push systemic TPA or do you put giant cannula in? And so what was the team talking about at the time?
Yeah, so I think that if someone is peri-code or peri-arrest, then systemic TPA is definitely an option, particularly if they're actively arresting. But on sort of medium doses of epinephrine and levofed, she was stabilized in the ICU. So for that reason, I think TPA was abandoned as an option. But at the same time, there's concern that as these thrombectomies are done, sometimes there can be more distal embolization of clot, which can potentially worsen obstructive shock in RV failure. So for that reason, the sort of safety net of an ECMO was implemented.
So very interesting case. So I was thinking, I don't routinely use pulmonary angiography. So if you look at this CTA, it was not that impressive to have a systolic blood pressure of 60.
Yeah.
So based on this experience, would you recommend every patient to have CTA and pulmonary angiography? Because many times, the contrast load we consider, and the CTA is still considered as the gold standard versus pulmonary angiography.
So I think that kind of requires a case-by-case assessment. So in this case, there was a pulmonary angiogram done in the beginning, but not one done at the end because she had an AKI at 2. I think if your CTA is high quality and it shows enough clot burden to explain the obstructive shock, then it may be reasonable to not attempt a pulmonary angiogram. But I guess in this case, the pulmonary angiogram showed more clot burden.
Was this case done under moderate sedation?
Actually, this was done under general anesthesia because she was intubated even before she came to the ICU.
Okay. Yeah, these cases definitely scare me. So I appreciate the fact that you considered VA ECMO and initiated that early on, because that's probably what allowed this case to turn out to be very successful and safe. At our institution, we do quite a few of these, and I didn't have a tremendous experience with complex PE prior to joining our group, but I've grown to appreciate the complexity here, and bravo, because I think this was done perfectly.
Yeah, I think moving forward, we're going to need more established guidelines on when to escalate these patients to be ECMO.
One of the caveats to PE, which this really does a great job of pointing out, is when we do these patients with moderate conscious sedation, when you intubate them, they get very, very, very sick, because that increased intrathoracic pressure bangs against their preload dependence of the failing right ventricle. And so VA ECMO in this situation was a great way to seize control of a complicated situation. I mean, this was also someone with a peritonsillar abscess, right, and who was critically ill from that. You might have gone up and take a handful of clot out, and she might have still been incredibly sick, because we don't necessarily know what's driving the hemodynamic decompensation. So you guys did a great job controlling the situation and fixing the problem.
Yeah, I think the critical care folks got a little lucky here because the intubation occurred before she became hypotensive. But arguably, the intubation led to her hemodynamic instability because that preload dependent, people with RV failure are often preload dependent, and we see in folks with severe pulmonary hypertension, once you intubate them, their blood pressures tank, and it takes quite a while to get them back up. But yeah.
What are the thrombectomy devices you guys use, and which case you choose? Because ECOS, JEDI, Penumbra, Inari. So is there any particular algorithm you follow to choose the cases?
So I guess at our institution, the experience has been with ECOS and Inari. I think to date there's no clear study that has shown superiority of one over the other, but I think the Peerless trial is currently underway, looking at this very question. I think that if there is proximal clot, it's quite reasonable to go with the Inari, and particularly if there are contraindications to thrombolysis.
Yeah, lots of questions remain to be determined. Peerless is being sponsored by Inari to kind of start diving into some of these questions, and we'll get more information as we go. One of the situations where, again, this case kind of speaks to a perfect example is thrombectomy. You're done after the thrombectomy is done, and so a lot of times in situations where you have someone on ECMO and they're going in front of you, and Flame was talking about that, in these highest risk PE patients, we'll think about thrombectomy. Whereas on the other side, some of the ultrasound CDT data shows some, like the Blush study results with distal tissue perfusion, just like we think about an acute arterial limb. So we're really working out the indications and the use, and I think you guys made great decisions in a really complicated multi-step process here. So.
Thank you. I would like to thank Dr. Lee, who supervised both of these cases.
You want to do a third one? You want to just make one up as we go?
Next year.
Thank you so much. Next year. Oh, you didn't hear him. He said next year when I asked about doing a third. That was great. With that, we'll invite our last presenter up, Dr. Samantha Espinoza, who will be talking about percutaneous intervention of surgically repaired partial anomalous pulmonary venous return.
Hello, good afternoon, everyone. Thanks for letting me present today. My name is Sam Espinoza. I'm a third-year general cardiology fellow at Mayo Clinic in Florida, and we'll be presenting this case from Dr. Peter Pollack. No disclosures. So this is a case of a 49-year-old gentleman who presented with symptoms of progressive dyspnea on exertion. His recent cardiac history was notable for an anomalous left upper pulmonary vein with associated RV enlargement and PFO, and these had been surgically corrected 3 months prior to his current presentation with anastomosis of the pulmonary vein to the left atrial appendage and concomitant closure of the PFO with a tricuspid repair. On the left here is his baseline CT imaging with reconstruction demonstrating the anomalous pulmonary vein connecting to the vertical vein and then innominate, and intra-op imaging or image showing the final surgical result of the anastomosis of the vein to the left atrial appendage. So prior to discharge, a baseline cardiac CTA was obtained, and on this initial image, they did know that there was some increased density at the anastomotic site, initially attributed to post-op edema, maybe some inflammatory changes, possibly a limitation of the CT image itself. However, when he was seen in follow-up 3 months later, he was having these progressive dyspnea symptoms, and so repeat CT was obtained, which demonstrated persistence of that density there at the anastomotic site and additionally reduced contrast into the corrected pulmonary vein. Further imaging was obtained with a VQ scan, which demonstrated perfusion abnormalities from the left upper lung consistent with a functional stenosis here. So the question became, how do we address the stenosis of the anastomotic site? And, do we take this young patient back to surgery again to reattempt to fix, or do we have percutaneous options? And so TEE was performed, which was helpful in confirming that the anastomosis was indeed still patent, demonstrating accelerated flow through the anastomotic site with aliasing of the color flow Doppler, and elevated velocities, again, consistent with stenosis. So the decision was made to attempt a percutaneous intervention here to open up the stenotic site. Access was obtained with a 14 French sheath via the right common femoral vein. A standard transeptal puncture was performed in the posterior septum to help access the left atrial appendage. This was then exchanged for a direct steerable guide sheath, and subsequently a multipurpose catheter was used to help traverse into the left atrial appendage with a stiff wire crossing the anastomosis. And so on the left you can see the baseline image demonstrating that really tight stenosis there, but there is still patent flow to the anomalous vein. And some baseline measurements were taken to help plan the procedure. A 6 millimeter balloon angioplasty was performed with care taken to slowly and serially dilate to minimize trauma to the tissues. And you can see the immediate post image on the right side demonstrating improvement in the anastomotic site and no evidence of extravasation or rupture. So the team then proceeded with implanting a 10 by 29 millimeter Genesis bare metal stent, and this is post-dilated with a 10 millimeter balloon. And on the right is the final result showing a widely patent stent with excellent flow, as well as distal flow into the end of the left atrial appendage. So immediately post-procedure, actually, the patient, sort of in the post-op area, had noted improvement in his dyspnea subjectively, and this persisted to even 1 year after. He was seen in 1 year follow-up and was feeling well, and 1 year CT scan is shown here demonstrating patency of the stent. So some of the learning points for this case were, one, to have an high index of suspicion for pulmonary vein stenosis here in someone that had undergone a surgical repair, and also highlights the importance of multimodal imaging to help confirm the diagnosis. So CT was helpful in demonstrating the anatomic issues, whereas VQ scan was helpful in demonstrating the functional troubles. TEE was also helpful in demonstrating that the anastomotic site was indeed still patent and that there were percutaneous options that could be attempted. And the intervention itself was also unique in combining techniques from other procedures such as left atrial appendage closure with more routine pulmonary vein stenosis interventions, including stenting. Thank you.
Great case. Tough case. Made it look easy in a couple slides. That's great. Did you guys talk about covered stents versus uncovered stents in this previously surgically repaired area that you were kind of deploying metal in?
So my understanding, based on more of the experience with more typical pulmonary vein stenosis interventions, is use bare metal or drug-eluting stents. Kind of hard to decide between the two. So I think just based on experience, that's why they went with bare metal stent. But as I mentioned, they were concerned about possible damage to the tissue, and so they did have covered stents available as sort of a bailout.
So again, great case. One question and one comment. How did you size the stent? Did you think about using IVUS? And the comment is, this patient cannot have Watchman in the future.
Right. I don't believe they used imaging to help size the stent, so it was mostly just based on the fluoroscopic images.
One of the things we'll talk about, and it's so funny, we always forget about it, but we have the CAT scan, and so we'll oftentimes think to the CAT scan as we're sizing. In a previously surgically repaired stricture, it's anxiety provoking. But at the same time, with pulmonary vein work, it's getting bigger as it comes down. So you have to worry about anything undersized, being watermelon seeded out. So what did you guys do afterwards in terms of medical care? He's now got a stent sitting in a low flow state in the pulmonary vein.
Right. So there's not a lot of great documentation on the sort of nuanced decision here. Based on what I had seen for more typical pulmonary vein stents, if it's over a centimeter, generally recommend warfarin for about 12 months, and then kind of afterwards, a little unclear. For smaller stents, you're going to keep people on anticoagulation longer. In this situation, he'd actually been on warfarin immediately post-op because of the stenosis, and so I'm not sure if they thought maybe he had failed warfarin, and so decided to sort of just switch strategies altogether after the stent went in. And so he was actually prescribed Eliquis and Plavix after the procedure.
Cases in Austin because, so a lot of EP ablations.
We see some, yeah. So it's really a developing field with a lot of ablation technology. It's something you got to be thinking about. We don't do a ton of them. I think everyone tries not to do them, like in everything, right? You try to do as little as possible, but in situations where it arises, it's helpful. And one of the things that's so striking about making it look easy is just pulmonary venography is really hard. Getting that picture where you're across the septum, where you can see so beautifully, that area of stricture. A lot of it is trying to match up angles to what you saw in the CAT scan and size based on the CAT scan and make some of those decisions. So really, really nice case. All right.
Great, thank you.
Thank you so much. And I think with that, we will conclude our session. So thank you guys. Thank you to all the presenters. Thank you to CVI for bringing everyone together. Really wonderful job done across the board.